Hi, my name is Brianna Fair, and this is a systematic review of imaging comparisons of spinal alignment among standing positions in healthy adolescents or adolescents with idiopathic scoliosis. Adolescent idiopathic scoliosis, AIS, is assessed using repeated x rays during growth, typically every 6 months. Many centers have recently acquired low dose EOS systems to simultaneously acquire a frontal and sagittal image to model the spine in 3D. The arms must be elevated when capturing the sagittal view to visualize the vertebrae, and this has been shown to affect sagittal angles of the spine, such as kyphosis and lordosis. The purpose of the study was to systematically review the literature on the effect of arm positions on spinal parameters in adolescents with AIS and healthy spines. The effect on sagittal parameters was our primary objective. For our methods, we searched 4 databases. These were Spinal, Embase, Medline, and Web of Science. To build the search, we used relevant terms for population, full spine imaging limited to standing, imaging parameters of interest, positioning descriptors, and all case reports and diagnoses other than AIS, injuries, or pregnant participants were excluded. This strategy was informed by scoliosis experts, a master's student, and a health sciences librarian. Our selection process started with title and abstract screening done by 2 independent reviewers. The criteria that had to be met for healthy participants was over or including the age of 10, and patients with AIS must be between or including 10 and 18 years old, with Cobb angles over 10 degrees and compared arm positions and standing. Once we selected relevant titles and abstracts, 2 independent reviewers screened the full text to ensure selection criteria was met and uploaded to Covidence. If there was disagreement, a consensus discussion was held between reviewers. If needed, a third reviewer made the final decision. Percentage agreement was also calculated between reviewers. Data extraction was completed by 2 independent reviewers. Data included sample descriptions like age and sex, diagnosis, curve type and severity, imaging methods used, any spinal measurements reported, position descriptors, and descriptive statistics. Risk of bias analysis was done using the quality appraisal tool for cross-sectional studies, known as AXIS. The text was given a final score out of 12 and a corresponding rating. A score of 1 to 3 was considered low quality, 4 to 7 was moderate, and over or including the score of 8 was considered high quality. Summary statements were formulated based on AXIS quality assessment and the homogeneity of results for each outcome characteristic. The table shows the options for quality assessment and the corresponding description. As an example, for an outcome of interest to be considered moderate evidence, there must be at least one high-quality study and consistent findings in one or more low-quality studies that report on the said outcome. We used a random effect meta-analysis when more than 2 studies reported on the same parameter and positions. Standardized mean differences, SMD, or mean differences were reported. SMD was reported if there was a difference in measurement scales reported in the selected articles. Heterogeneity I-squared statistics were reported. Our search found 1,332 studies after 108 duplicates were removed. After screening, 33 made it to the full text review. Finally, 7 studies were included for data extraction. Screening agreement was over 97.5%. The most common positions used were standing, fists on clavicle, and active positions where the arms are raised and unsupported, as shown in the figure below. The most common parameters measured were kyphosis, lordosis, and sagittal vertical axis, SVA, and our quality appraisal rated 2 studies as high quality, 3 as moderate, and 2 as low quality. We were able to meta-analyze kyphosis, lordosis, and SVA measurements for habitual standing compared to the clavicle position. Across 2 moderate quality studies and 1 low quality study, there was a significant median effect size of 0.78, where kyphosis is smaller in the clavicle position. Across 2 moderate quality studies and 1 low quality study, there was a significant large effect size of -1.21, where lordosis is larger in the clavicle position. For both kyphosis and lordosis, the heterogeneity was low. Lastly, across two moderate quality studies and one low quality study, there was a significant mean difference of 30.59 millimeters, where SVA is shifted more posteriorly in the clavicle position. This analysis presented substantial heterogeneity of 67%. We were also able to meta-analyze kyphosis, lordosis, and SVA measurements for active positions compared to clavicle. Across one high quality and two moderate quality studies, there was a non-significant and negligible effect size of 0.03 for kyphosis between the clavicle compared to the active position. This analysis had substantial heterogeneity of 56%. Across one high quality and two moderate quality studies, there was a non-significant and negligible effect size of negative 0.06 for lordosis between the clavicle compared to the active position. Lastly, across one high quality and two moderate quality studies, there was a significant but small mean difference of negative 2.01 millimeters, where SVA is shifted more posteriorly in active positions compared to the clavicle position. This analysis had substantial heterogeneity of 83%. We formulated a total of 24 summary statements. In habitual standing, two statements concluded no difference in whole kyphosis and lordosis compared to active 30-degree and passive 30-degree positions. There was conflicting evidence in kyphosis compared to clavicle, a significant increase in lordosis compared to clavicle, and a posterior shift in SVA compared to active 45 and 30, as well as passive 30 in clavicle. In the clavicle position, conflicting evidence was found in whole kyphosis compared to passive 30, active 45 and 30, and hands on wall. A significant decrease in T4 to T12 kyphosis was found when compared to hands on wall and active 45. No differences were found in lordosis compared to active 45 and 30 and hands on wall. Lastly, a significant posterior shift in SVA was found compared to active 45 and 30 and hands on wall. Some limitations to the study were that we only included adolescent populations within our search. We limited to standing positions only. We excluded languages other than English. Only 4 databases were searched. The reviewers were considered novice, although they reached a high percentage of agreement when screening, and differing measurement methodologies used among the studies may have effects on our meta-analysis. The table here is a summary of the data that is missing from the current literature. So what is missing? Positions that expose the hands for skeletal maturity assessment have not been compared to habitual standing. Across the literature, a limited number of positions have been compared. The literature seldom reports on relevant frontal and transverse parameters like curve severity and AVR twist, and there is very limited evaluation of AIS populations. In conclusion, there's overall limited evidence from the current literature in this topic. Our meta-analysis shows that the clavicle position does not compare to habitual standing, as it decreases kyphosis, increases lordosis, and posteriorly shifts the SVA. Similarly, there are significant posterior shifts in SVA when the arms are elevated. Active positions appear to most shift the sagittal profile and do not represent habitual standing. One summary statement shows a significant posterior shift in SVA comparing an active position to passive, and therefore these may not be interchangeable. Active positions, hands on wall, and clavicle were also shown to not be interchangeable. It remains unclear which arm position best represents habitual standing. I'd like to thank the following people and sources of funding for their support throughout this study. Thank you for listening.